welcome to this session on arterial blood gas analysis. ABG is very frequently done investigation in ICU, and the interpretation in the clinical context is very important. So the idea of giving the clear picture of understanding the arterial blood gas analysis in this part 1 of the session, with the objectives of understanding of the physiology, that is the oxygen dissociation curve, its relevance to the understanding of ABG. Then what are the sampling precaution at the initial level when we are trying to send an ABG? What is the basic acid base chemistry we should have the understanding before interpretation, and basic understanding of oxygenation, the AA alveolar arterial gradient, calculation of compensation in the ABG to define whether it's simple or a mixed disorder. Then discussion on the common acid base disorders, calculating the anion gap and the delta gap, and steps in the bedside interpretation of arterial blood gas. These topics will be covered in the part 2 of the session with interesting case-based discussion. So let's go first the most important physiological concept of oxygen dissociation curve. So if you draw a curve and take on the x-axis is your PO2 value, partial pressure of oxygen in the blood, and on your y-axis is the amount of hemoglobin which is saturated with oxygen, SaO2. So if we draw a curve and understand the relationship, we will highlight the various points of clinical importance. Now this curve is a sigmoid shaped curve, that is a S-shaped curve, and you see the critical aspect where it turns down. This is the critical area that is corresponds to the saturation of say 90%, and the PO2 corresponding is 60. So this is of clinical relevance, that any saturation drop below 90%, there is a steep fall because this is a steep part of the curve, and this is even a small drop in saturation will cause a major drop in the PO2. So major drop in PO2 will be seen, but above 90% you see there almost is a flat curve, so there is no much change in the PO2, and that's why in clinical context, like in recent pandemic of COVID also, we kept a target of say saturation of 90%. We assure the PO2 more than 60. If we see when the hemoglobin is saturated to 50%, the PO2 corresponding PO2 is 27 millimeter of mercury. So this ODC curves helps us to understand that what is the physiological target to keep, that is this oxygen saturation and PO2 level. At the same time, it helps in understanding that if there is a acidosis, there is a Bohr's effect, that is this curve will shift to the right. So there will be more free oxygen in the blood than which is attached to the hemoglobin. This happens during acidemia or acidosis. Second, it will happen when there is increase in temperature or there is increase in 2,3-DPG, that is 2,3-diphosphoglycerate, which you see in the anemia. On the contrary, the hemoglobin will be tightly bound to oxygen when there is decrease in temperature. So this curve will shift to the left here if there is decrease in temperature and there is no much oxygen requirement by the tissue, so it will be attached to the hemoglobin in case of drop in the 2,3-DPG or in case of alkalosis. So this actually curve gives a relationship. Say PO2 is what you find in the ABG, and saturation what you find in the pulse oximeter. So you can have the indirect relationship you understand between the saturation and the PO2 values. Coming to the sampling part, we know that most of the sampling in ICU is often done by the junior most or by the sister on duty. The doctor consultant right to do an ABG. So we should first define, like, it is an invasive process, so it's often painful, so we should have a clear indication in mind. What are the sites we will advise to prick? What are the precautions we should take? When should you send an ABG? So you have taken a patient on ventilator, immediately you should send, or you should send after 10 minutes, 15 minutes, 20 minutes. And how do you send the sample? So whether you send to the lab or you have point of care machine, and how does the sample transport causes the erroneous reading, that we should know. So first question, as in ICU, for before any investigation we ask, why am I advising to do ABG? So ABG, arterial blood gas, should not be just a routine order. You should have your diagnosis and clinical context in your mind, what you are trying to find out in the ABG. So arterial blood gas, whether you are doing for oxygenation, whether you are doing for identifying the acidemia, whether you are trying to find out the high anion gap or low anion gap, differentiating the acidosis, or you are trying to find a circulatory problem where you want to check the veno-arterial PCO2 gap. This all will cover in the second part of this ABG session. So clinical context is important. Then whether the patient is on invasive, non-invasive ventilation, you want to define the success or failure of the non-invasive ventilation. You see the PCO2, PO2 values, that will give you the idea. Whether you want to define the severity of ARDS, like in Berlin's definition earlier, they have clearly defined the PO2 values which are going to study, and the hypercapnic or hypoxic respiratory failure. So more often you will see that it's done in the hypercapnic respiratory failure to see the PCO2 value. Then acute circulatory failure, as I told, the VA PCO2 gap of more than 6 will give an idea. And certain times there are mixed disorder and complex acid-base disorder condition in which you will like to do the arterial blood gas. But remember, it is a invasive process, so you should have a clear indication in mind. With the advent of pulse oximeter and end-tidal CO2, the use of ABG should be definitely justified. What should you advise? And this is often forgotten test, that is the Allen's test. What does it say? The most frequent site is the radial artery. So if you see that there is a radial artery and there is a arch in the hand and there is a collateral ulnar. So you have to check the patency of this arch before you prick the radial artery because of risk of vasospasm, hematoma, blockage in future. So what is important is to do the Allen's test. So in Allen's test, modified Allen's test, the normal blanching time is 5 to 15 seconds. So this is taken illustration from Erwin Rippe's standard textbook of critical care. Let's see what the modified Allen's test is.
Make the fist of the patient's hand.
So you make a fist.
Second step is to obstruct the radial and the ulnar artery simultaneously of the patient.
So both are blocked and you can see the...
Then open the hand. You see the pale color.
So blanching is seen.
Now to check the intactness of the collateral, release the ulnar side.
So ulnar side is released and there is a blanching.
The original color has returned. That means
within 5 to 15
the
seconds.
collateral
So
is functional.
yes.
And there is no risk of radial cannulation.
So we can do radial cannulation. The test doesn't show that there is any problem with the collateral circulation. This is the most important thing which is forgotten. Now, depending on the sites of sampling, the most preferred, as I told, is radial artery. Brachial artery is the end artery, should be avoided. Femoral artery, high chances of infection, hematoma, bleeding, arterial puncture, spasm, then fistulas, then infection. So it should be avoided. If you have arterial line, you should know how much dead space has to be left, and then you have to take a sample to prevent the erroneous reading. And always be careful about the complications of pain, bleeding, infection. So that is the most important secondary problem which can be created. So you have to rule out the risk of hematoma, AV fistula, pseudoaneurysm. This has to be avoided because this being an invasive procedure. Now, what are the various sampling errors which should we be aware about? Earlier, the ABG sample was best done in the glass syringes because there is no diffusion of oxygen from the atmospheric air, glass being impermeable. And that was preferred, and you could see that the glass syringe plunge going back, and when you are in the artery. But you have to flush the syringe with the heparin. Now, this excess heparin used to cause in the syringe used to cause is being acid. The interpretation error leading to metabolic acidosis or respiratory compensation, and significantly altered the lowering of PaCO2, PaO2 and base excess. So with the advent of new syringes which are already with heparin coated syringes, they are available, so this error can be avoided. Second is if there is a point of care use machine, the delay in processing can be avoided. But then the blood sample in the syringe, if it's more than 15 minutes and the blood being the living live tissue, so the RBCs will utilize the oxygen and production of carbon dioxide, and that's why delay in processing will affect your interpretation about these important values. How to avoid? Of course, you put in the store sample in the ice, so the metabolism is delayed, and process this sample as early as possible. Sometimes the sister or the young doctor is taking a sample, and they may take inadherent venous sampling, so your oxygenation will not be reliable in such situation. The doctor has not seen the flash of blood while collecting, and blood results are not consistent with the clinical context. So if you find a venous sample with a PO2 definitely will be low, you cannot label it as respiratory failure and high PCO2 and SpO2 on the pulse oximeter. So definitely it's a mixed or sometimes inadherent venous sample. So that is one of the errors. Then dead space, if you keep a high in the syringe, or if there is a air bubble. Now if the PO2 is high, there will be diffusion of gas from dead space to the air bubble, and will lead to inadherent inaccuracies in your PO2, PCO2 and pH values because of the diffusion of the oxygen. If PO2 is low, it will be inadvertently high, and if it is high, it will be showing inadvertently low. So always see that the sample is free from the air bubble. Waiting time before sampling is important. So when you are changing the setting, when you are when you are taken the patient from invasive to non-invasive to invasive ventilation, at least wait for 15 to 20 minutes, or at least 5 to 10 minutes, so that the oxygenation and CaO2 content is stabilized or steady fast state before you send a sample. As I told, avoid delay in processing. So if you have a machine in the ICU itself, rapid care, convenience, less turnaround time, but you should have a clear indication. It should not happen because you have point of care ABG machines, more samples are being done, so that should not be the case. Now coming to the question, with advent of pulse oximeter and ATCO2, does the pulse oximeter give same information as arterial blood gas? What is your answer? Take a moment. Okay, 90% of the time, yes, but there are limitations of pulse oximeter. If you have a patient in shock, if you have a patient with high Apache score, if you have a patient with cold peripheries, if your patient has a nail polish, or ambient light, which all affects the pulse oximeter. Apart from this, if there is a saturation gap or difference between the arterial PO2 and pulse oximeter reading, you should suspect some dyshemoglobinemia, which will not be picked up by pulse oximeter. You need to have a co-oximeter in situations like methemoglobinemia and carboxyhemoglobinemia. So in this situation, if you suspect these toxins, then your saturation SpO2 may not be reliable, and you may require ABG in carboxyhemoglobin, because carboxyhemoglobin and oxyhemoglobin not differentiated by the pulse oximeter, which works on the wavelength and of the red and infrared, and you need to have a co-oximeter if you have clinical suspicion of methemoglobin or carboxyhemoglobin. And if methemoglobin more than 30%, you may have to treat with methylene blue. So these cases we'll be discussing in our subsequent session. Now let's understand the component of ABG report. So if you see on the left side, you see that the ABG gives the value of pH, then PCO2, partial pressure of carbon dioxide, partial pressure of oxygen, PO2. These are the three direct electrodes. Then bicarbonate is actually a calculated value, SCO3 standard you will get, which is at the PCO2 of 40, and then other values like nowadays ABG, you will get the electrolyte, you will get the lactate, you will get the ready-made anion gap, you will get the percentage of methemoglobin. So many things you can get from the single arterial blood gas report. So let's understand this basic chemistry, acid-base chemistry. So what is pH? So pH is a negative log of hydrogen ion concentration. So what does it mean? So whenever the H plus increases, so hydrogen ion increases, there is the pH drops, and when the pH drops, there is acidemia. If the H plus on the contrary decreases, the pH increases, that is alkylemia. Now our body functions in a quite a narrow range of 7.35 to 7.45. Most of the cells in the body will work at this range, and if pH is less than 7.35, this acidemia will have lot of cardiovascular effect. We have seen in ICU patient with resistant acidosis develop arrhythmias, cardiac depression, neuromuscular effect, hyperkalemia, hypophosphatemia, all electrolyte imbalances. And similarly is the case with alkylemia, where the patient with severe alkalosis may have seizure, may have neuromuscular effect. CO2, low CO2 can cause vasoconstriction to the cerebral vessels and effect on electrolytes. So the body has various compensatory mechanisms to keep this pH in the range of 7.35 to 7.45. Anything less than 7.35 is acidemia, anything more than 7.45 is alkylemia. Actually, if you see, the life is a acidogenic process. So whatever we eat, like glucose, protein, lipids, they all produce carbon dioxide. Now the two main organs which play an important role in keeping the pH of the body normal is, one is the respiratory system, other is the renal system. So if we see, the CO2 is taken care by the respiratory system. So the non-volatile acids like sulfuric acid, methionine, phosphate, proteins, fatty acid, acetoacetic acid, beta hydroxybutyric acid, these are taken care by the renal system. So whenever, that's the reason why in say patients with high CO2 or like COPD patients, we tell them try to avoid the glucose containing, because there is high CO2 formation. So high carbohydrate is avoided because the respiratory system cannot compensate for that over certain limit. So if we see what are the various ways in which body keeps the pH to normal. So first is the extracellular buffer. Now buffer system is the quickest, or which works within seconds. So what does it does is, whenever a strong acid is added to the buffer system absorbs excess hydrogen, preventing a large drop in pH. And whenever the strong base is added, the buffer releases the hydrogen ion, counteracting the rise in pH. So these buffer system, like phosphate buffer system, protein buffer system, bicarbonate buffer system, these are quickest to act to maintain the pH to normal. Similarly, the respiratory system and the renal system, the difference is the respiratory system will work within minutes. So if you see the patient of say metabolic acidosis, so the respiratory system tries to compensate by increasing the respiratory rate and washing out the CO2. CO2 is nothing but a volatile acid, it's carbonic acid, so volatile acid. So you have seen the patients of like diabetic ketoacidosis or renal failure who are having heavy breathing, they are trying to breathe out that oxygen. That is a compensatory mechanism. So they are breathing out that excess acid through CO2. Similarly, the renal system in respiratory conditions. So if you have acute respiratory acidosis, CO2 is high, the kidney will try to increase the alkalosis, or will try to absorb the bicarbonate, but this system is little bit slower to act and take 24 to 48 hours. So depending on this compensatory mechanism, in metabolic acidosis or metabolic condition, respiratory system compensates within minutes by blowing out the CO2, and in respiratory problem like respiratory alkalosis or respiratory acidosis, the kidney functions to compensate now, but the kidney takes a little time, 20 to 48 hours. That's why we have two conditions like acute respiratory acidosis without much renal compensation and chronic respiratory acidosis with renal compensation. Similarly, we have acute respiratory alkalosis without renal compensation and acute and chronic respiratory alkalosis with renal compensation. So these compensations can also be calculated with the help of a formula. So now what it starts is the arithmetic blood gas, where you can actually calculate the amount of compensation. So let's see the revision part of it. So if there is an acute respiratory acidosis, in acute condition what happens, the CO2 is high, so the acute respiratory acidosis, the kidney will not compensate immediately, so there will be 1 milliequivalent of rise in bicarbonate for every 10 milliequivalent rise in PCO2 above normal. So if it is 40 becomes 50, the bicarbonate will increase by 1. From 22 it will become, if you take a 24 it will become 25. In chronic respiratory acidosis, the kidney will be able to compensate and more bicarb will be retained by the renal system. So 3.5 milliequivalent will increase per 10 millimeter rise of PCO2. In respiratory alkalosis, the things will be opposite. The PCO2 is going down. The bicarbonate 2 milliequivalent per 10 will be reduced, or in chronic it will be 5 milliequivalent per 10 millimeter of mercury. So you can remember as formula 1325. So 1 acute respiratory acidosis, 3.5 chronic respiratory acidosis, acute respiratory alkalosis 2 for every 10 rise, and chronic 5 for every 10 drop in PCO2. What happens in metabolic acidosis? You can calculate the expected PCO2, that is 1.5 times bicarbonate plus 8 plus minus 2. So if suppose there is a bicarbonate level, standard bicarbonate is 10. So 10 means 1.5 times 10 is 15 plus 8, that is your 23 plus minus 2. So if your PCO2 you have calculated is 23 and you see in your ABG, compare with your ABG, and ABG shows a PCO2 of say 22, it matches, that is a primary metabolic disorder. But suppose the PCO2 is high, it is showing 30 and you are calculated 24, 22, that means there is additional respiratory acidosis. That means the patient might be having pulmonary edema or he is not able to compensate for this metabolic acidosis. Similarly, in metabolic alkalosis, the formula is 0.7 times bicarbonate plus 21 plus 1.5. So you don't have to mug up this, but when you try to calculate the compensation, you should keep this in your some corner of your ICU, write it down, do it regularly, and you will be able to remember. Especially the winter formula is often used for metabolic acidosis, like 1.5 times bicarbonate plus 8, that can be easily taken care or remembered. So these are the formulas which we have discussed, and these are from the standard textbook of Hall's critical care. You can see the change in bicarbonate within 24 hours, and after 24 hours there is a renal compensation. So what are the normal values we should remember? The pH mean value of 7.4, then anything below 7.4 is acidemia, anything more than 7.4 is alkalemia. PCO2 of 40, anything less is respiratory alkalosis, anything more is respiratory acidosis. Bicarbonate 24 is the mean, with less than 24 acidemia metabolic, and more than 24 is alkalosis. So that's what we should remember. Now coming to oxygenation, the PO2 is an important component in ARDS, pneumonia, most of the respiratory failure we do, and we can calculate the age predicted PO2. So with increasing age, the PO2 can be expected PO2, you can calculate from the FiO2. So if somebody has room air, so 21% oxygen, or 20 into 5, you can remember 100 is the expected PO2 for the normal healthy young person. But if his age is more than 40, more than 60, or anything more than 25 or age, you can have this formula of expected PO2 is minus PO2 minus 0.3 into age minus 25. So this is easy to remember. Then calculation of the alveolar arterial gradient. So amount of oxygen in the alveoli, PA capital AO2 on the arterial difference will help us to find out whether the disease is because of hypoventilation or because of the diffusion defect. If the shunt fraction is more than 20%, the best thing to calculate is PaO2 by FiO2 ratio, that is partial pressure oxygen by fraction of inspired oxygen. If it is less than 200, it's respiratory failure. We will see this in a definition of ARDS for oxygenation. Before going for further oxygenation, let's see one interesting case. This patient was long back shifted in our intensive care with respiratory failure requiring invasive ventilation. This female was of leukemia. The ABG sample collected in 1 hour after stabilization, and with FiO2 of 1, that is 100%, minute ventilation 8 liter, respiratory rate of 16, and saturation on the pulse oximeter was 96%. What did we get in the ABG is the pH of 7.2, acidemia, PCO2 normal 39, PO2 of 11.1, bicarbonate of 18.6, and how to explain this low PO2 disparity with SpO2. So first thought which we came to our mind is this ABG sample is with error. So whether you have taken too much of heparin, whether the sampling error is there. But you can check the validity of the ABG. That is the first step, which we will be learning in the second session, to how the steps of checking the ABG. So this was valid report. Now how to explain this disparity? Patient was stable with normal saturation but low PaO2. So as I told, the clinical context is very important. So it was asked that when was the sample taken. So sample was taken, say, at the evening 7 o'clock. When was it processed? It was processed at 8 o'clock in the lab because there was a handover time. And when we saw the second report, which is also here the patient of leukemia, if you see the WBC count was 29,07,000. Now you understand what must have happened within the sample. So within the sample, the WBC utilized all the oxygen, and what value you got here was the pseudo hypoxemia. So in malignancy patients. So this is about the leukocyte larcency or pseudo hypoxemia, artificially low PO2 in the ABG due to markedly increased oxygen consumption by the malignant leukocyte. So in these instances, you may rely on your pulse oximeter, or better to process your sample as early as possible rather than waiting, and this will give the true picture. Coming to hypoxia and hypoxemia, as I told, the PO2 values of less than 60 to 79 we saw in the ODC curve also is a mild hypoxemia, 45 to 59 is a moderate hypoxemia, and less than 45 millimeter of mercury is a severe hypoxemia. So there is a critical values for PaO2, and in ARDS we are all aware that we target a PaO2 of 55 millimeter of mercury. We don't target the near normal 60 to 80 hypoxia, because we are aware that long term, if you see at the mitochondrial level, it's just 2 to 3 millimeter of mercury of oxygen is required for the aerobic metabolism. And if you see the long term cyanotic heart disease patient or the people who have climbed the mountains like Everest and all, if you take their ABG, you will find low PO2 without any lactic acidosis. So this is all about the time, duration, context, clinical context. So that is what is important when you are interpreting and treating these patients in the ICU. So for convenience and for discussion, PO2 of less than 60 at the room air oxygen, where we expect saturation oxygen PO2 to 80, it is less than 60, it is a type 1 respiratory failure, and PaCO2 more than 50 is considered a type 2 respiratory failure. As per the new definition of ARDS, after Berlin definition, they saw that in COVID era we have used first the onset of ARDS was delayed, and we have seen that after 8-10 days also patient used to develop. In Berlin definition, it was within 7 days of inciting event. To cover up that and to see that we use of non-invasive ventilation and high flow nasal oxygen is also increased, and to prevent these indolent cases from missing from the ARDS definition, especially in the low resource country, they have come up with this PO2 FiO2, and if you cannot afford the saturation and FiO2 ratio, so pulse oximeter saturation less than 97 divided by your fraction of inspired oxygen, that is if it is less than 315, it is a mild, then if it is less than 235 it's moderate, and less than 100 is a severe ARDS. So this new definition. And in high flow nasal cannula patient to be included if they have on 30 liter per minute or NIV or CPAP with PEEP of 5 centimeter of water. The definition holds true if they have the they can be considered as a ARDS if SpO2 FiO2 is less than 315. So this is the importance of knowing this new definition. Then importance of calculating the alveolar arterial gradient, as I told. So how to calculate the alveolar oxygen tension. So alveolar oxygen tension can be calculated by FiO2 760 is the atmospheric pressure, minus 47 is your water vapor pressure. This turns out to be 713, and if you it should be ideally done at the room air, that is 21% oxygen. If you calculate this, turns out to be around 149.5. So this value is say 150 minus PaCO2 you see on the ABG divided by 0.8, or divided by 0.8 is the respiratory quotient. So normally you will see the 5 to 10 milliliter mercury. If it is more than 20, then it is abnormal. So this calculation of A gradient will help us understand about hypoxia, whether if it is normal gradient it is alveolar hypoventilation, like in post-operative patient with basal atelectasis or who was breathing is shallow, or if there is a lower inspired oxygen itself is causing the hypoxia. If it is raised, then it is a diffusion defect, most common the ventilation perfusion mismatch, or right to left shunt like intrapulmonary or intracardiac shunt, or sometimes sepsis where increased oxygen extraction is there. Now this A gradient has to be taken into consideration the age factor. So normal gradient for say 60-year-old will be 60 plus 10, 70 by 4. So as it will more than the 10 value. So the limitation is the age and the high FiO2. So in this situation, PaO2 by FiO2 to calculate the shunt more than less than 200 is reflective of shunt more than 20% is important. So to understand this A gradient, let's have a quick this patient of 40-year-old ABG is given. What is A gradient if it is normal limit of the age? So pH is 7.48, PCO2 30, PO2 100. You have to calculate the A gradient using this formula which I have shown you about FiO2 760 minus 47, that's 150 minus PO2 by R. So what is your answer? Is it within normal range first, and question is whether it is appropriate for the age. So do take time to solve this before we meet in our next session, where we are going to cover the steps in analyzing the ABG, some interesting cases, and we will try to understand the anion gap and delta anion gap. Till that, any doubts, any queries, you can email me at practicaltips@gmail.com. Thank you for your attention.